Depression has many phases. Can you imagine that somatic pain, lack of energy and easy fatigue could be a main symptoms of depression?
Krka Talks podcast, where we share knowledge and personal thoughts with healthcare professionals and the general public.
Welcome to Krka Talks. I have an honor to present here today my dear colleague Piotr Wierzbiński. My name is Ante Silić. I'm a psychiatrist from Zagreb. I work in University Hospital Sestre Milosrdnice. And today, me and my colleague will be talking about depression. So it's a huge subject. Where do we start?
We start that every of us have a patient with depression, and this is the serious epidemiologic problems, especially after COVID and because of life. Yeah, we have different life, like 20 years ago, 40 years ago. The people live in different way. We have overstimulation from many factors, and the people try to change something. So the first step to depression is diet and lack of sleep. And it's a next step is sad mood, lack of energy, and we have many patients with energy and battery off.
One of the things that we hear these days, the World Health Organization has been saying to us, all of us, that depression is moving forwards in numbers. And then it actually did so. It went from the fifth place to the second place, now even the first place. And then we can hear some criticism about it, that we are doing the inflation, that we are modifying the diagnostic criteria in the era of transition from DSM-4 to DSM-5 or ICD-11 and so on and so forth. So basically, is there really more depression these days, or it's something artificial? What's your opinion on that?
My opinion is simple. I have many patients in my practice, and the people suffer from depression because of biology, because of lifestyle, because of stress. We should change the point of view for depression, yeah, because many of depressions now is a comorbidity, with anxiety, and we have many factors who are important in the etiology, like hypercortisolemia, stressful life events. Many of us don't want to sleep well. We have no any physical activity. So this is the problem for our whole body and the brain. And hypercortisolemia is a main etiological factor for depression. We have immunological changes in our brain. It lasts many months. But I have patients who are depressed many years or many months, yeah, because they don't know what happened to me. I started to be sad. I have a problem with sleep. I have anhedonia, apathy, energy. I feel pain, yeah, because we should talk about it, that if we have hypercortisolemia, because of hypercortisolemia, we have elevated level of interleukins. Interleukins is inflammatory cytokines. So we decrease the level of noradrenaline and serotonin in the brain. And that's why we feel more pain before the depression. So we have many patients who go from the doctors to doctors, from cardiologists to gastrologists, from gastrologists to neurologists, and they try to diagnose, they try to find out what's happened to me, and if they come to psychiatry, we prescribe the drugs and they improve.
After the era of 3 cyclics or 4 cyclic medicine, which were cardiotoxic and everything, came the era of SSRIs, which is a perfect era because we reduced the side effects, but we didn't improve the efficacy. And then finally, we have a new dual multimodal, and add-on drugs for treating depression. What, in your opinion, primarily as a clinician, as a practitioner, would be the first line? Where do you see the typical new age patient with the first line therapy?
Very good question, because we should focus on the patients and we should analyze the symptomatology, because we know that if you have lower serotonin level in the brain, you feel more anxious, you are impulsivity, you suffer from suicidal thoughts, sexual dysfunction, and you are irritable very quick. Yeah. But if you have lower noradrenaline level in your brain, you suffer from lack of energy, fatigue, cognitive dysfunction, and you feel more pain. If you high level of noradrenaline, you feel your pain threshold is higher. So, in my opinion, nowadays we have more patients with fatigue, energy, apathy. They have no battery, as I said. So this is the problem, because not every, but most of us, most of psychiatrists think about anxiety as a first line, anxiety as mood. So the first line treatment, many years, is escitalopram or sertraline, etc. And look at this. You prescribe these drugs, and after the 4 months, the people come back to you and said, "My God, doctor, it's quite good, but I have no energy. I have difficult with concentration. My planning is not good. What's happened to me? I have in the morning feel better." So this is the proof that we should think about SNRIs. We should think about the antidepressant drugs who increase the 2 neurotransmitters like serotonin and noradrenaline. And why? Because this patient should be treated with SNRIs, because his symptomatology is for SNRIs. We have 2 SNRIs on the market, venlafaxine and duloxetine. And what is the main differences between 2 drugs? Duloxetine is stronger and much easier to prescribe the patients, because usually effective doses is 60 milligrams. If you think about venlafaxine, so you should prescribe 375 milligrams the patients. It is an equal dose like 60 milligrams of duloxetine.
Somewhere, and risk hypertension.
Hypertension and side effects are could be often than duloxetine, because duloxetine, if you prescribe 60 milligrams, for example, you increase the serotonin, because duloxetine is a strong serotonin reuptake inhibitor. And strong noradrenaline reuptake inhibitor. So you increase serotonin and noradrenaline, so you achieve the improvement in anxiety and in the lack of energy, sad mood, and apathy. So this is important. How to choose drugs? Analyze the symptomatology, because based on monoamine hypothesis, we know that disbalance in serotonin, noradrenaline, and dopamine is responsible for main symptomatology. And many of our patients suffer from sad mood, cognitive dysfunction, and suffer from anxiety and lack of energy.
Exactly. I think that, again, one thing that I would like to point out is, tell me if you agree or disagree, absolutely, that we should not fall into the trap to pronounce that exclusively any kind of class of antidepressants or drugs that show antidepressant activity, whether they are antipsychotics or mood stabilizers or any other, are the sole and exclusive first line. So basically, we are coming to the era where any antidepressant should be considered a first line.
I agree with you. If you compare the efficacy in the meta-analysis or randomized control studies, so the efficacy of two classes if similar. But if you compare the true efficacy based on meta-analysis, you have SNRIs as a more efficacious drug than SSRIs. Why? Because most patients have a dichotomic dual symptomatology, not pure serotoninergic symptomatology. We have more patients with noradrenergic and serotoninergic symptomatology. So for me, if you ask me what is the first line treatment, every drug is equal, but the better response you have after the SNRIs, because two neuromediators are stronger than one neuromediators, and this is the clinical practice show it.
Yeah, exactly. I couldn't agree more, because we are maybe under-treating if we are just looking at one class and one molecule as a first line and losing time. And then definitely the guidelines should be there, but not as something that we cannot be creative about.
For me, the important is compliance and the relationship with the patients. So if I prescribe SSRI or if I choose SNRI, the time from the onset of the treatment to the onset of the drug start works, it's much better in SNRIs.
Should bring back the compliance and therapeutic alliance if you show if the improvements show up faster rather than later. So exactly. If you had to wrap up or conclude this talk that you just gave in a couple of sentences, what would be the most important points that you would?
Okay, the key facts for our practice is we should describe the patient, and we should choose the drugs based on symptomatology. So we should define the patients and describe the symptoms. You need more serotoninergic drugs or more adrenergic drugs, or you need both. And the next step is adequate doses. We should remember that our drugs, the modern drugs, are quite safety, but we should prescribe adequate doses, because too small is not effective, and usually the doctors have tendency to prescribe lower doses. For me, adequate doses like 60 milligrams of duloxetine or higher. And the third point is that we should focus on patient and compliance and use the adequate doses and explain patients that in some cases you should wait for the drugs.
Perfect. Yeah, I couldn't agree more again. And I must say that what comes to mind is that we have chosen a pretty demanding job, both of us. Thank you, Piotr, for this wonderful and insightful conversation.
Thank you. Thank you for a nice talk, and it's my pleasure.
And thank you for following this Krka Talks, and be sure to stay tuned for the next one.
Krka, because we stand by you for health, knowledge and motivation.